Let's begin with the first section of our lecture, Tumours of the Nasopharynx and Oropharynx. And in this section, we will discuss about the benign tumors of the nasopharynx. And in this, we will talk about the classification of the tumors of the nasopharynx, then nasopharyngeal fibroma and its extension, and also we will discuss about some other benign tumors of the nasopharynx. So the benign tumors of the nasopharynx, benign tumors, as we know, are the tumors which are localized, they are less malignant, they do not metastasize, and they are easy to treat and less destructive also. So benign tumors of the nasopharynx. We have angiofibroma is a benign tumor. Angio is for the blood vessels. Choanal polyp. Polyps are the mucosal protrusions or bulgings which form the polyp, and polyp can be a sessile polyp with no stalk attached to it, or it may be the pedunculated with the stalk attached to it. So polyps are another type of the choanal which arise from the choana. So it's another type of the benign tumor of the nasopharynx. Then we have squamous papilloma. It's a benign tumor. Thorn-walled cysts, pleomorphic adenoma, craniopharyngioma, paraganglioma, hematoma. All these are the benign tumors, and the oma is wherever you see the word oma, that's the tumor. So all these are hematoma, paraganglioma, craniopharyngioma. These are the benign tumors of the nasopharynx. Then we have congenital tumors. Benign tumors of the nasopharynx can also be congenital tumors. They are present at birth or is congenital in origin. So that's also the benign tumors of nasopharynx. Then let's go over some malignant tumors of the nasopharynx. Malignant tumors, they metastasize, they have the ability to spread to distant size, they are more destructive, poor prognosis. So benign and malignant tumors. So malignant tumors of the nasopharynx are the carcinoma nasopharynx, then we have lymphoma, rhabdomyosarcoma, chordoma, plasmacytoma, then we have hemangiopericytoma, malignant salivary gland tumors, and melanoma. All these are the malignant tumors of the nasopharynx. So carcinoma, nasopharynx, lymphoma develop from the lymphatic system lymphomas, rhabdomyosarcoma develop from the connective tissue, soft tissues. Then we have chordoma, plasmacytoma from the plasma cell, hemangiopericytoma, malignant salivary gland tumors, and melanoma. So all these are the malignant tumors of the nasopharynx. Then the nasopharyngeal fibroma, which is one of the benign tumor of the nasopharynx, and it's also known as juvenile nasopharyngeal angiofibroma. It's commonest but rare. Again, it's commonest among the benign tumor, but it's rare also. So it means these tumors are not as such very common tumors. They are the rare type of the tumor. But among the rarest, this is the commonest type. The causes of the nasopharyngeal fibroma is the exact cause of this tumor is not known. It's not clear what are the causative agent of the nasopharyngeal fibroma. It is thought to be testosterone dependent. So the testosterone, which is the male hormone, it depends on this testosterone hormone. So the exact cause is not known, exact etiology is not known, but it is supposed or it is believed that it is testosterone dependent type of the tumor. Hematomatous nidus of vascular tissue in nasopharynx that activate to form angiofibroma. So this tumor is basically, it begins as hematomatous nidus of vascular tissue. Is the site of vascular tissue blood vessel growth in the nasopharynx that is activated, stimulated, and it becomes angiofibroma. So that's the concept behind the development of this nasopharyngeal fibroma or angiofibroma. Site of origin and growth of this fibroma is the earlier belief. What was the earlier concept about the development of this nasopharyngeal fibroma is that it develops at the roof of nasopharynx or anterior wall of the sphenoid bone. So originally it was thought that this tumor developed from the roof of the nasopharynx and the anterior wall of the sphenoid bone, and then it is believed that it is from the posterior part of the nasal cavity. So this is the nasal cavity. From the posterior part of the nasal cavity, it develops close to superior margin of sphenopalatine foramen. So there are differences in the concept early and now that depend on the site of origin of this tumor. Earlier it was believed that it is from the roof of the nasopharynx or anterior wall of the sphenoid bone, but now it is believed that it is from the posterior part of the nasal cavity close to superior margin of sphenopalatine foramen. And this is the histological picture of the nasopharyngeal fibroma. The extension of nasopharyngeal fibroma, how it extends and how it grows. Here in this diagram, you can have a better picture of the location of the nasopharynx. That's the nasal cavity, and then the tongue. This is the cancer which is present in the nasopharynx. The upper part of the pharynx at the back of the nasal cavity. This is the nasal cavity. So the upper part of the pharynx here, you can see behind the nasal cavity, this small portion is the nasopharynx. Very little part is the nasopharynx. Then bigger than the nasopharynx is the oropharynx. That's behind the oral cavity. And then below that there is hypopharynx. Hypo means low or below. So these are the three anatomical divisions of the pharynx. We have very small nasopharynx behind the nasal cavity. Then we have oropharynx behind the oral cavity. And below that there is hypopharynx. And that's the site of location of the cancer of the nasopharynx. This is the tongue. So how this cancer can spread or extend? It can extend to the nasal cavity very easily because the nasal cavity is very close. It can extend to paranasal sinuses, which are the air-filled empty spaces around the nasal cavity. We have ethmoid sinus, frontal sinus, maxillary sinus. All these are the sinuses which are present around the nasal cavity. So this tumor can extend to the paranasal sinuses also. And then it can extend to pterygomaxillary fossa, infratemporal fossa, and cheek. So all these are pretty much the surrounding areas. This is the temporal region, so infratemporal fossa, pterygomaxillary fossa, and to the cheek. It can spread there. Orbits giving rise to proptosis and frog face deformity. So when it spread to the eyes, orbits, eyeball, it caused proptosis, bulging out of the eyeball, and the frog face deformity. The deformity produced by that extension into the orbit is known as the frog face deformity. And it can also extend to the cranial cavity or the skull. So these are all the sites where the nasopharyngeal fibroma can extend. All these are the surrounding structure, and once it spread and infiltrate, it can spread to these localized surrounding areas. Clinical features of nasopharyngeal fibroma: there is profuse, recurrent, and spontaneous epistaxis. Bleeding from the nasal cavity is common, recurrent, or spontaneously it's present. Progressive nasal obstruction and dental speech, denasal speech, sorry. So it's progressive nasal obstruction and denasal speech. Because of that obstruction, the sound produced is known as the denasal type of speech because of the progression of the tumor into the nasal cavity, and it's causing obstruction to the nasal cavity also. So that's called the denasal speech. Then we have conductive hearing loss and otitis media with effusion. That's also the presentation of the nasopharyngeal fibroma. Conductive hearing loss, the sound is not conducted through the external ear and then through the middle ear. Conduction is affected because of the spread of the tumor or obstruction, and also there is otitis media also, which is the middle ear infection. Mass in the nasopharynx, definitely if there is a tumor or growth, there is mass in the nasopharynx present. Then we have the broadening of nasal bridge is also there because of the tumor. In the nasopharynx, there is broadening of the nasal bridge. Proptosis, when the tumor spread to the orbit or the eyes. Swelling of the cheek with the spread of the tumor to the cheek, and there is also infratemporal fossa or involvement of cranial nerves with the spread of the tumor to the cranial cavity. So all these are the clinical features which are maybe due to the localized presence of the tumor, but mainly when it starts spreading to the surrounding area, these features are produced depending on where the extension of the tumor is or where it is extended. So these are the clinical features of the nasopharyngeal fibroma. Diagnosis and management of the tumor, we have the CT scan and MRI, very helpful in the diagnosis of the mass or the tumor. Then we have carotid angiography, which is the angiography is the picture of the carotid artery to look for the presence of the tumor or spread. Carotid. Then we can do biopsy with control of bleeding. Bleeding can occur with biopsy. When tissue is removed, then it's important that we should have the measures to control that bleeding. The surgical approach for the treatment, we have transpalatine approach through the palatine or palate, transpalatine plus sublabial approach, and this approach is known as Sardana's approach. Then we have lateral rhinotomy with medial maxillectomy. Rhinotomy is the opening of the nasal cavity or nose. Rhinotomy. Maxillectomy is the removal of the maxilla. Ectomy is the removal, otomy is the opening. That's the difference between two very close related terms, otomy and ectomy. And then the other approach, surgical approach, is the transmaxillary, which is also known as Le Fort 1 approach. Maxillary swing approach or facial translocation approach. This is another approach, wise operation, and maxillary and the facial translocation approach. Infratemporal fossa approach. So all these are different approaches. The approach to the tumor is selected or picked depending on where the site of extension and what site or what approach can be the most effective for the removal of the tumor or its extension. So depending on what will be the most beneficial approach for the tumor, that approach is then accepted or decided to go for. So infratemporal fossa approach. Then we have also intracranial, extracranial approach. Radiotherapy in the amount of 3,000 to 3,500 in 15 to 18 fractions delivered in 3 to 3.5 weeks. So another is radiotherapy in the dose of 3,000 to 3,500. It's given in divided doses of 15 to 18 in 3 to 3.5 weeks. Then hormonal therapy, we said it's believed to be associated with testosterone hormone. So the diethyl stilbestrol and flutamide, DES and flutamide can be used for the treatment. And then chemotherapy is doxorubicin is the chemotherapeutic drug used for the treatment of angiofibroma or nasopharyngeal fibroma. So all these are different options for the treatment. We have surgical approaches, we have medical treatment, we have radiotherapy, and we have the hormonal therapy available. Vincristine is another chemotherapeutic drug. So doxorubicin and vincristine. Dacarbazine. So all these are different chemotherapeutic drugs that can be tried. Other benign tumors of the nasopharynx, we talked about the nasopharyngeal fibroma, which is, we said, is the commonest, but again, rare also. It's commonest among the rares. So other benign tumors of the nasopharynx include, we have the congenital tumors, and in the congenital tumors we have hairy polyp, true teratoma, and epignathy. Then we have pleomorphic adenoma, chordoma, hematoma, choristoma, and paraganglioma. All these are other benign tumors of the nasopharynx. And then the congenital tumors of the nasopharynx include the hairy polyp, true teratoma, and epignathy. And then also we have paraganglioma, chordoma, hematoma, and choristoma. All these are different benign tumors of the nasopharynx, which is the portion of the pharynx behind the nasal cavity, small portion of the pharynx. And we already discussed about the extension of the nasopharyngeal fibroma. Where does it extend? Which surrounding areas are affected by the extension or the spread? This was all about the section 1, in which we talked about the benign tumors of the nasopharynx. Thank you for watching sqadia.com.